Welcome, everybody. This is another episode of Beyond the Headlines, and I am thrilled to have two luminaries in the field today talking about some recent research that came out, referred to as the CHAPS trial. And we're going to learn a little bit more about that trial and why it is so significant to clinical care and what patients can expect now moving forward regarding treating chronic hypertension in pregnancy. So let me first start with introductions. We've got Dr. Judette Louis, who is with us from the University of South Florida and associated medical institutions. She is the former president of the Society for Maternal Fetal Medicine. And we also have with us Dr. Tita, who is with the University of Alabama in Birmingham, and was one of the key investigators on the CHAPS trial. So we're really keen to hear from both of them to learn more about the trial itself, the findings, and the impact on clinical care that we can expect from obstetricians. So let's start with a little bit about the trial. And Dr. Tita, I'll start with you. If you could just tell us why it was done and what the significant findings were from this trial.
Yeah, absolutely. And Eleni, thank you for the invitation. Glad to be here. The CHAP trial was done because there was an international controversy regarding whether to treat women with non-severe chronic hypertension, that is pre-existing hypertension prior to pregnancy. There were concerns about whether treatment is associated with adverse pregnancy outcomes for the baby, especially impaired fetal growth, and whether treatment, on the other hand, is beneficial for other outcomes. So because of that uncertainty, the CHAP trial was undertaken to provide and throw some light to that question.
And what were the key results? Like, what did we learn? What did the CHAPS trial contribute to our understanding of this that we didn't know before?
Yes, so the CHAP trial was undertaken at about over 70 US sites. We enrolled women with non-severe chronic hypertension at 61 sites and randomized them to get treatment in the active arm to control their blood pressure to less than 140/90, and in the no treatment group, they were indeed treated, but only if their blood pressures progressed to the severe range. And so we enrolled just over 2,400 women and found that treatment to a goal less than 140/90 was associated with improvements in the primary outcome, which was an outcome that included one or more of preeclampsia with severe features, preterm birth for medical reasons prior to 35 weeks, abruption of the placenta, which can be catastrophic, and stillbirth or neonatal death. We also found that treatment to that lower goal was not associated with impaired fetal growth. So birth weight for the population being less than the 10th percentile, which can be associated with neurodevelopmental issues and stillbirth, was not significantly increased by treatment. We also found improvements in preterm birth overall, as well as in low birth weight infants as well. We looked at a composite of severe maternal outcomes, including some cardiovascular outcomes, as well as a composite of severe neonatal outcomes. These two outcomes were relatively rare, just under 3%. And we did not see any differences, even though the frequency of these outcomes appeared to be lower in those who received treatment. So in a nutshell, those are the key findings from the CHAP trial.
So Dr. Louis, if we could bounce to you for a second and ask, as a maternal fetal medicine specialist and on behalf of the society, Does a trial like this, how does a trial like this impact the practice guidelines that specialists would need to adhere to, and possibly obstetricians, general, what we call generalists, would adhere to?
Well, this study is so important because it addressed a gap in our knowledge, right? The gap was, whether or not you had to start treating when blood pressures were lower than severe, right? Before they hit severe. And so what's phenomenal is that this data shows that yes, you get better outcomes if you start treating earlier. And so not waiting for the mom to have blood pressures that are in the severe range before you initiate that treatment is associated with better outcomes. And so based on that, certainly SMFM has come out with guidance to say that, yes, you should start treatment. We recommend it. Do not wait until the hypertension is severe.
And can you just expand a little bit more on that? Like when should that treatment begin? And is it being treated to try to get mom's blood pressure to 140/90 or below that? Like what exactly would be the goal here?
Yeah. And so in the study, the goal was to 140/90 or below. And so if you have a patient whose blood pressures are higher than that, but have not reached the severe range, what we're saying is we do recommend that you start treatment with the goal of getting them below 140/90.
Gotcha. And so that's coming out of that is guidance that's been put out by the Society for Maternal Fetal Medicine. Dr. Tita, I realize you're not necessarily speaking on behalf of ACOG, the American College of OBGYNs, but ACOG has also come out with guidance. Can you tell us a little bit about what they're and what they're saying? Because the actual phrase that's in their guidance is ACOG recommends utilizing 140/90 as the threshold for initiation or titration of medical therapy for chronic hypertension and pregnancy, rather than the previously recommended threshold of 160/110. So to the general obstetrician who maybe isn't being called in as a specialist, what's the take-home message for clinicians? And then what should patients be expecting?
Yeah, first off, I would like to comment that it is really fantastic to see the professional organizations follow on with guidance so soon after the trial. Both ACOG and SMFM, kudos to them. And just to break down my understanding of the guidance from ACOG is that, yes, for non-severe chronic hypertension, as well as severe, for which there was a consensus to treat to a goal less than 140/90 millimeters mercury going forward with appropriate medications. But also importantly is the fact that because there was this concern about the safety of the medication, patients or physicians would withdraw medication for patients who they thought had mild or non-severe chronic hypertension. So going forward, when patients present, then early in pregnancy, continue their antihypertensive medication. With the new, this is not part of the guidance, but with the new definition of chronic hypertension in the general population, where a threshold of 138/80 is being used as opposed to the 140/90, which is currently being used in pregnancy, we may see a few more women present with medication because they were started early out of pregnancy. But I don't expect that to be a very big population, because most women will not meet, even with chronic hypertension on 130/80, will not meet the criteria to get on medication. But for those few who come, I think the question will be whether to keep them on their medication or to continue. I just want to say these CHAP findings do not speak to that very small subset. For the vast majority on patients chronic hypertensive on medication continue their therapy.
Okay, all right. So a couple of other questions. One, aspirin. We've been talking about aspirin now much more aggressively in the last couple of years. How does aspirin affect this trial? And how does this trial affect the ongoing recommendations regarding aspirin.
Right. I'll take that and then turn over to Dr. Judette. So one of the interesting things in the study, we found that early at the time of randomization, just about 46% of participants in both groups were taking aspirin. But then when we followed at the time, by the time of delivery, approximately 80% were, which is great. And I think early on that was because the recommendations as to start aspirin for this high risk condition, chronic hypertension, later. So with that set up, to speak to your question, the findings of CHAP do not affect the recommendation to treat women who have chronic hypertension with aspirin to prevent preeclampsia. We did an analysis where we looked at patients who were on aspirin in a subgroup analysis. I don't think it's reported in the paper. The patients who were on aspirin and those who were not, and the effect of treatment did not differ by whether they were on aspirin or not. So regardless, treat them to the goal less than 140 over 90, and also give them the aspirin as recommended.
Got it. So Dr. Louis, I'll ask you to address another question that we have, and because you were kind enough to serve on our racial disparities task force. And I'm wondering if the findings of this trial provide any added opportunity to address what may have been, and this is perhaps what the question is, gaps in care that have contributed to some of the disparities that we're seeing in Black women, in Native Americans, et cetera. Is this an area, is this an opportunity to address some of the gaps that have potentially contributed to some of those disparities, or is that a whole separate issue?
Yeah, I think the heightened attention around the topic is an opportunity. One of the things that we do find is that, minority populations are more likely to be uninsured or underinsured, which means a delay in them initiating prenatal care and not having access to care before they get pregnant, which means chronic conditions such as hypertension tend to be undertreated. When they do receive the care, they are more likely to receive care at places like federally qualified health centers, or clinics that have a high turnover in staffing and don't necessarily follow guidelines due to a number of challenges. And so I think the heightened attention to hypertension and treatment of hypertension right now is an opportunity. It's an opportunity to make sure that those who are, managing patients in those settings have the information, have the right education regarding what the guidelines are, and that these guidelines are for everybody. There can sometimes be, structural misinformation, that in medical school, you're taught, racist beliefs, and that, Black people just have hypertension. And so then a higher blood pressure is tolerated for them, because it's just expected that they have hypertension and it's not being treated. So again, this is an opportunity for us to get the word out there, to educate those who are providing the care, those who are writing the prescriptions, that you need to treat it. And it's the same guideline for everyone.
Mm-hmm. Treat to the numbers. Don't make assumptions. Absolutely.
Correct.
So last question. The AIM bundle, which is really it's not even a protocol, but it's sort of a framework for how hospitals should be treating severe hypertension in pregnancy. So this tends to be more closer to time of delivery. That is the one place that we most clearly see this threshold of the 160 over 110. Don't do anything until they're at 160 over 110, and then then it's an emergency. So what effect could or should this trial and these findings and the guidance out of ACOG and SM-FM have on potentially changing that bundle? And this may be an opinion question, but that's okay. I'm asking your opinions.
All right. So yeah, I was that's a terrific question, and it's one that I've heard recurrently as we've discussed CHAP. I would be upfront in saying that these are two related but different scenarios where we are treating chronic hypertension early in pregnancy. But also, even those patients with chronic hypertension are at risk for that hypertensive situation complications later on in pregnancy, as are those who do not have chronic hypertension. I think that the implication here is that we need to look closer at that guideline and evaluate it and do additional studies to see whether we get a similar beneficial impact on pregnancy outcomes and the women's health outcomes by intervening. I really don't think that, I think that we cannot use CHAP to change that guideline, because there are potentially side effects that may be applicable to that population, but not to the CHAP population. So closer scrutiny, more evaluation to see whether that guideline should stand or not.
Dr. Louis, your thoughts?
No, I 100% agree. And one of the important things about these AIM bars, they seek to improve safety, decrease morbidity and mortality. But one of the things that we're realizing is that it can't just be in the inpatient setting. So the CHAP trial didn't address, what's the right parameter for inpatient, but certainly it's addressing what's the right parameter before they get to the hospital. And I think that is so important, that if you walk in healthier, if you walk in with a reduced risk of preeclampsia, and some of these other morbidities, then you emerge doing better. And so I think it's a different question, and very important that, we look at them separately.
Gotcha. So certainly there is, if you were to identify research, where is the proverbial further research is needed. Further research is certainly needed in that inpatient setting, just to see if similar findings carry through to that emergent situation. So just to wrap up here, I guess, certainly feel free to throw in anything else that's relevant, but I feel like the take-home message for patients, and of course then associated for clinicians, is if you have chronic hypertension going into your pregnancy, one of the take-home messages is absolutely continue to treat it. And if you haven't been treating it, treat it. And there are medications that are safe to take during pregnancy. They may need to be adjusted, but there are medications safe in pregnancy.
Right.
And then once you're into the pregnancy, if you develop what would be called chronic hypertension or gestational hypertension, you're not waiting to that 160/110 emergency level to start treating it. And that's true for at any point in that pregnancy, but particularly early on when it might present. So those sound like a couple of the key takeaways that we're hearing from the CHAPS trial. Treat it before you get pregnant. And if you get pregnant and then get hypertension, treat it. Don't wait for those super high levels.
Yes, I would agree with that, right? We're talking about patients with chronic hypertension. Always stay on treatment to a goal less than 140, and even during pregnancy, if there is an increase, then do an adjustment to get it below 140/90. But later on in pregnancy, it's very important to know that these patients with chronic hypertension are at very high risk for superimposed preeclampsia, and it's not just about adjusting their medication, but to make sure that they don't have superimposed preeclampsia, which is associated with added harms.
Yes, yeah.
I guess Dr. Louis had a comment, and then I would like to comment a little bit more about research, additional research implications.
Yes.
I didn't have anything additional.
So I agree with the research implication to look at that later group to see whether treating them to a goal less than 140/90 is potentially beneficial. I think it's also important to look at these women, especially women, the CHAP cohort, who benefited from treatment to see whether there are longer term benefits, right? Preeclampsia is associated with more cardiovascular outcomes later in life. Do they benefit? And we are currently funded by NHLBI to follow up these women long term. So that's great. The other research implication, I think, is also to follow up these kids to see whether are there long-term benefits as well, because there will not be an opportunity to have these two groups that, you know, got treatment and did not get treatment. And so maybe there are additional benefits that patients and, you know, populations and physicians should be aware of. So following up these women, the kids as well, would be great.
Fantastic. Thank you both so much for your time. This has been another edition of Beyond the Headlines. We will include links to the study and some of the guidance that we've been referencing today in the comment section of this video. But thank you so much for watching. And thank you to Dr. Louis and Dr. Tita for your time today.
Thank you.
Thank you for having me.